My name is Anson Rosenfeld, and I'm a physical therapist and a member of the Knowledge Translation Task Force for the Clinical Practice Guidelines for the Physical Therapist Management of Parkinson's Disease. Today, we will be talking about the aerobic exercise recommendation from the CPG and ways to implement that in a clinical setting. Very briefly, the objectives of this presentation are to review the CPG recommendations about aerobic exercise in PD, to discuss appropriate safety screening prior to initiating an aerobic exercise program, to discuss the FIT principles, and to describe special considerations unique to PD and aerobic exercise. The CPG recommends that physical therapists implement moderate to high intensity aerobic exercise to improve aerobic capacity, reduce motor disease symptoms, and improve functional outcomes in individuals with PD. The evidence quality is high and the recommendation strength is strong. So this informational video will highlight some key elements when it comes to implementing an aerobic exercise program in this patient population. So the first question is, prior to initiating an aerobic exercise program, how do you screen your patient to ensure that they're safe and ready to initiate a program? There's several pre-participation screens that you can use. The PAR-Q is one, and in front of you, you see the American College of Sports Medicine's pre-participation health screening form. And in this example, it's a really nice flow sheet that takes into account current activity levels, signs and symptoms of certain metabolic, respiratory, and cardiac diseases to guide you to a planned exercise intensity and specific clearance that may be needed. But the big key for this change, which happened in 2015, is that most people can initiate an aerobic exercise program. And aerobic exercise is generally safe for the majority of people. Once you have decided to initiate an aerobic exercise program with your patient, how does the FIT principle, frequency, intensity, time, and type, apply to this patient population and apply to the CPG? First is frequency and time. Current studies that were included in the CPG indicate that somewhere around 3 times a week for 30 to 40 minutes is likely adequate to achieve the benefits we discussed earlier in terms of aerobic capacity, reduced motor disease symptoms. Next metric in the FIT principle is intensity. And one of the key ways that intensity is measured during aerobic exercise is with heart rate. Now, there's a variety of heart rate straps that one can wear. There's chest-mounted ones, forearm-mounted straps, and there's wrist-mounted straps and watches that all give you an idea of what an individual's heart rate is during activity. I encourage you to go to the Intensity Matters clinician tools and resources. They have created a really comprehensive toolbox that gives a great overview of different types of activity monitors and heart rate. So what you're viewing here are some screenshots from the Intensity Matters website at the ANPT. They have these heart rate reserve and heart rate max calculators that are really helpful. So in general, when you're recommending aerobic exercise, we want it to be moderate to high intensity per the CPG. So moderate to vigorous intensity is classified as 70 to 85% of heart rate max or 60 to 80% of heart rate reserve. So the big difference between heart rate max and heart rate reserve is that heart rate reserve takes into account resting heart rate. So you would want to have your patient lay supine for about 5 minutes, get that resting heart rate. The Intensity Matters website has Excel sheets that you can download. Input your patient's information in terms of resting heart rate, age, beta blocker status, and then it will give you this range of 60 to 80% for heart rate reserve and an age estimated max. And it does the same thing if you're using a percentage of heart rate max. You input the age and beta blocker status, and it will give you the range from 70 to 85%. And with the beta blockers, the target heart rate ranges will decrease by 10 beats per minute. Now, a normal physiological response to exercise from a heart rate perspective is displayed here in this figure. Here you see an individual who comes in with a resting heart rate in the upper 70s to low 80s. They do about a 5 to 10 minute warm up, get into their target heart rate range, which is outlined here in gray, sustain that target heart rate range for the 30 to 40 minute exercise duration, and then their heart rate starts to drop during the cool down period. Blood pressure will follow a similar response. It will start low, raise during exercise, and then come down during the cool down period. So ACSM defines an exaggerated blood pressure response as a systolic of greater than 190. So if your patient approaches or exceeds that number, you need to back off the intensity of your intervention. And then diastolic blood pressure should remain relatively stable with exercise, and an increase or decrease of more than 10 may warrant further medical workup. Now, individuals with Parkinson's disease may experience autonomic dysfunction, which may alter what we would expect or the normal physiological response in terms of blood pressure and heart rate. So orthostatic hypotension is a relatively common condition in individuals with Parkinson's disease. So to test for orthostatic hypotension, you can have your patient lay supine for 5 minutes, take their blood pressure, then go immediately to standing. They'll stand for 1 minute. After that 1 minute standing period, you'll take their blood pressure, have them stand for 3 minutes, and take the blood pressure following 3 minutes of standing. So orthostatic hypotension is defined as a decrease in systolic of 20 millimeters of mercury or a decrease in diastolic of 10. And this will typically be accompanied by signs and symptoms such as nausea, dizziness, lightheadedness, or a loss of balance, either subjective or objective when transitioning or standing. If your patient does experience orthostatic hypotension, they are more likely to experience an exercise-induced hypotension. And this may be that when they stop exercise, that they experience those symptoms of lightheadedness or dizziness, etc. Certainly things like hydrating is an important thing, managing their electrolyte balance. Prolonged warm-up and cool-down periods can be helpful. And then when they get off the piece of exercise equipment, they may need to stay seated for a little bit. Orthostatic hypotension is challenging to treat, and please stay tuned to our YouTube channel for some videos with our forthcoming to further discuss this issue. Now, as I mentioned before, with autonomic dysfunction, oftentimes heart rate doesn't go up as anticipated. Right? So they have individuals have a blunted heart rate response. In that case, you would want to go to a different measure of intensity, something like a rate of perceived exertion or an RPE scale. So there are several different RPE scales. In front of you, you see a 10-point scale with 0 being no rest, or 0 being nothing at all, and 10 being maximal exertion. And here in this video, you see that when this individual is exercising, simply show him the scale and have him indicate what number he's at. So moderate to high intensity on a 10-point scale is an RPE of somewhere between 5 and 8. On a 6 to 20-point Berg scale, an RPE of 12 to 13 is considered moderate, and 14 to 17 is considered vigorous. The last principle of the FIT principle is type or mode of exercise. Now, there have not been very many studies that directly compare different modes of aerobic exercise to one another. And so there's important things to consider when selecting a mode for your patient. If balance or postural instability is an issue, seated exercises such as bikes, either upright or recumbent, or new steps may be preferable. Versus if your goal is to also work on gait training with the specificity of training principle, then either overground or treadmill walking may be preferable. And some of it does come down to patient preference as well and keeping the patient engaged. And some patients like to jump between different modes of aerobic exercise to keep themselves engaged. Regardless of the mode or type of intensity, it's critical to fit your patient to the piece of equipment. Here you'll see this individual is going to perform aerobic exercise on a recumbent bike. So just making sure that his knees, there's a slight bend in his knees, that he feels comfortable on the bike. And the same would be true with any type of aerobic exercise equipment. Every piece is a little different, and we need to make sure that the patient is oriented to how to adjust the resistance, the time, etc., to meet their aerobic exercise goals. Takeaway clinical conclusions here is that the majority of people with PD can benefit from a well-designed aerobic exercise program to improve aerobic capacity, reduce motor symptoms, and improve functional outcomes. And physical therapists certainly have the skills and knowledge to design and work with a patient to implement this type of aerobic exercise program. The program should in general be 3 times a week for 30 to 40 minutes at moderate to vigorous intensities. PTs and patients should collaborate to select the mode of exercise that meets the goals and preferences of the patients and really have the autonomy. Patients should have the autonomy to choose things that they enjoy and keep them interested. And to be aware of autonomic dysfunction, as it does play a large role in aerobic exercise prescription. On behalf of ANPT and the Knowledge Translation Task Force, I would like to thank you for your time and attention today.